Hello, my name's Julie McCrossin, and it's my pleasure to introduce two cancer doctors who are going to discuss how patient-reported outcome measures can be used in radiation oncology to improve the safety and quality of care for patients. And it's a great pleasure to welcome Professor Geoff Delaney, a senior staff specialist in radiation oncology at Liverpool Hospital in southwest Sydney, and also a professor of radiation oncology at the University of New South Wales, and Associate Professor Puma Sundaresan, another radiation oncologist working at Westmead Hospital and Sydney University, President of TROG Cancer Research, and also the Chair of Head and Neck Cancer Australia. So a big welcome to both of you.
Thanks, Julie.
Thanks, Geoff. I'll come to you first. You've got a patient and family member in front of you, and they say, what are PROMS, and why do you care so much about them?
So PROMS is a way of collecting patients' symptoms in a numerical score to give a clinician an idea as to what are the highest priorities for them or the highest, most burdensome symptoms that they might have. And they might ask, well, why do you need to measure it? Why not just ask me? And there are lots of studies that have shown that despite interactions between doctors and patients, doctors often misunderstand the importance of some symptoms over another. And so lots of studies have shown that the collection of PROMS actually improves the patient-doctor communication.
Okay, and Puma, how would you describe it? I always think it's worth hearing twice, and also why you're passionate about them, because I know you really are too.
I am, Julie. As Geoff said, patient-reported outcomes are direct reports from patients or their family members about their health status without any interpretation by other people, particularly clinicians. And patient-reported outcome measures, or PROMS, are the tools that we use to measure those outcomes, or patient-reported outcomes. You see, as clinicians, we've always sort of focused on survival, time to when disease progresses, or side effects as us clinicians would rate them. But traditionally, we haven't actually looked at the patient report as part of that process. Even though in the research setting in clinical trials for the past couple of decades, we've measured patient-reported outcome measures, patient-reported outcomes when we're comparing one treatment against the other. We want to see if one's better than the other in terms of controlling disease, and we looked to see if patients' quality of life, was okay and wasn't affected, and it wasn't a trade-off in the process of getting that extra benefit. But we haven't used PROMS in routine clinical care. It's only in the last probably decade or so, Geoff, jump in, that interest in really trying to look at incorporating patient-reported outcome measures as part of routine clinical care has become of interest to clinicians. And I guess that's come from recognition that to deliver truly patient-centered care and quality care, knowing patients' function and their quality of life is pivotal, and us clinicians may not be the best people to. We're not the best people to assess that, so we have to hear it from the patients themselves.
Look, I want to come, Geoff, to an example of a study that you've been involved in with the Prompt Care Study to illustrate the potential benefits that can come to patients from a study like this. So in a nutshell, what was its purpose and the key lessons you've learned?
My colleagues and I had been working for some time believing that point-of-care patient-reported outcome measures were important. But at that stage, we didn't really have a lot of hard outcome evidence of what impact it had, other than knowing that it improved patient satisfaction and quality of life. But the hard outcome measures like survival had never been looked at before. And a number of studies had attempted to use PROMS, but by collecting electronic PROMS in a different medical record or a different electronic file compared to the patient record. And largely those studies had failed. But we came across a group of researchers who were able to help us get the data into the patient record and to develop a system that highlighted the patients who needed highlighting based on their scores in the system. And that's essentially what we call prompt care. So researchers in southwestern Sydney and Illawarra Shoalhaven conducted a study on just over 400 patients where we developed this electronic system. But most importantly, behind the electronic system, we developed a model of care. And that meant that these scores were reviewed by the medical team daily, and actions were then made for the patients who identified a need. And the main outcome of that study was that compared to a similar cohort of patients who did not collect PROMS, we reduced emergency department admissions by 1/3.
Okay, that's significant.
And what that said to me was because the team was more alert to the patient's symptoms at an earlier stage and were able to address the symptoms in a way that negated the need for hospital admission. Now, while we were doing that study, a number of researchers overseas were also doing studies, some of them randomized trials. And the most interesting study that occurred concurrently to our study was that electronic PROMS capture and action led to an improvement in chemotherapy compliance and, more importantly, cancer survival. And once again, that's been interpreted to mean that if the team know about the patient's needs and toxicity and they address them properly, patients are more likely to comply with their treatment and tolerate their treatment and complete their treatment, rather than stop their treatment early due to toxicity.
I want to ask you something else in a moment, but I just want to ask each of you, just very concisely, 2 or 3 examples of the sorts of questions that might be put into a patient-reported outcome measure questionnaire, just so to get to the nitty-gritty of what you're asking the patients. Would you go first, Puma, just very concisely, the sort of questions you'd like to ask patients in a PROMS?
Concisely, I think it depends what you're wanting to know and what the purpose of a tool is. And there are a myriad of tools out there, a myriad of patient-reported outcome measures out there. So what's important, in my opinion, is that we need to know what it is that we want to learn from employing this particular tool. So if our purpose is to measure anxiety or distress in patients coming through the cancer service, then you might use a measure that looks at assessing those to, anxiety or distress. So the distress thermometer or, something like that would be the sort of tool that you would use. And just to give a bit of background, these tools are not just put together by a random group of people who just come up with some questions. Usually in developing patient-reported outcome measures, there's a standardized process by which patients, a large population of patients and clinicians, are polled to understand what the important issues might be, what the items might be. And then there could be focus groups and interviews conducted with these same groups of people to understand, unpack what those issues are. And those items might be formulated into questions, and then there will be some form of sort of field testing done with another group of patients to see if it makes sense, if what you're hoping to gain information on is actually being asked by the question. So I mentioned anxiety and distress, but in a head and neck cancer patient, for example, I might be interested in swallow function in their survivorship. So the types of questions that might be in a swallow or head and neck cancer patients, patient-reported outcome measure, whether it's part of this dysphagia inventory or other. It could be things like, do you cough and choke? Or do you cough when you eat or drink foods? Do you find you're choking on your foods? Do you find it's embarrassing to eat in public because you're coughing and spluttering? That's the sort of thing that would be asked. Have you felt the need to modify your diet, for example? So it's really specific to what it is that you're wanting to know.
Thank you. That's very helpful. And I can imagine with many different cancers, pain, reporting on pain would be another one. Could you give me a couple of examples, Geoff?
Yeah, I'd give you 3 headings. I think anxiety and distress is one, specific toxicity for the particular tumour that you're looking for, and unmet needs. They're probably the 3 main headings. And you're right, Julie, that pain would be a fairly common specific one for each cancer, but then there would be ones that are more relevant to, say, head and neck cancer than they would be to colorectal cancer, for example. And there are lots of validated questionnaires that you can then use to collect that data. One of the challenges, in fact, is trying to work out which questions to ask the patient without overburdening them with 125 questions, some of which are duplicated across multiple surveys.
And could I just ask you what, I think you said something toxicity, just what that means?
The side effects that the patient may be experiencing as a consequence of their cancer or as a consequence of the treatment that they're receiving.
Okay, look, a core purpose of this discussion is really to encourage radiation oncologists and their teams to integrate patient-reported outcome measures that are appropriate to their situation into routine care. And I know, Puma, you're very aware of some key barriers to that. But what I'd like to do, if I may, is to ask you, Geoff, to give us your 5, what you see as a checklist for success, factors that need to be in place for success. And then I'd love to come to you, Puma, if I may, as someone I know is going to be implementing PROMS in your workplace, I think, over the next 12 months, for your sense of what will be some of the key challenges to share that as well. So, Geoff, can you give us your checklist for success, the sort of 5 key things that need to be in place to make patient-reported outcome measures successful within standard routine radiation oncology care?
So I think firstly we need a workplace culture that embraces PROMS as an important and essential part of clinical care. We need clinical champions on the ground who are leaders within that health service to champion the importance and to maintain the rage. We need an electronic system that allows patients to fill out the questions in their own time and the data to flow in real time, and to have an electronic system flagging those with high scores.
But flow in real time where?
Into the patient record. 4, a model of care with clear identification of the clinical staff responsible for actioning PROMS. And 5, a health system that recognises the benefits of PROMS, where adequate resources are allocated to the collection and action on PROMS.
Look, thank you. Now, Puma, my understanding is you really think that these patient-reported outcome measures, these PROMS, can deliver benefits in real time to guide a clinician with the individual patient, but also to collect population-wide data. What is your response to those 5 keys for success when you're so aware of the challenges of implementation? Your thoughts?
It's hard to not focus on the barriers. You're absolutely right, Julie. I agree with Geoff. I think systems and processes to support the administration of PROMS, to collect the data, to integrate it into the EMR, into the main cancer EMR, I think that's key.
And that's the electronic medical record?
Sorry, the electronic medical record, because clinicians are busy, they're time poor. If everything comes into the same portal, the one point of truth, then that makes sense rather than expecting them to log on to 5 different things around the place. So I think systems and processes to administer, ideally electronically, at time points that make sense, and then collect the data, have it integrated into the electronic medical record, educating the clinicians on the value, as Geoff said, but also in the analysis, the interpretation of the data, because a lot of hesitation on clinicians' part, I think, comes from lack of confidence, lack of knowledge about how to interpret the data, and they worry that they won't be able to deal with the information coming through, and they won't know how to action whatever's arising from that data collection. So I think that's the second thing, education. Commitment and support at a service level, at a department or institutional level, I think is crucial, because it needs a culture change, it's a service level change. There needs to be commitment from leadership to allocate the resources that will be needed. This is not going to happen without appropriate resource allocation, whether it's infrastructure in terms of software for PROM collection, and whether it's staff to actually implement a care pathway to address an issue that's coming up. Stakeholder engagement, obviously patients need to be part of this process. Whatever process is implemented needs to be acceptable to them, needs to be feasible in that department. And if, there's a large population of culturally and linguistically diverse patients coming through, there needs to be, appropriate versions of the PROMS available for use with those patients in their preferred language. And champions, you need champions to, as Geoff said, to drive it, to be positive about it, because there are so many things that could not work, that are negative about it, that are hard to do. But it needs champions to just get in there and start wherever they're at with whatever resources they may have, and just get started and learn and build on whatever they've started. For example, there was a clinical trial that ran out of Blacktown Hospital in Western Sydney, the ADAPT trial, which was similar to the prompt care trial that Geoff mentioned before. But the ADAPT trial looked at anxiety and distress, depression in incoming new patients into the service. And initially, the service didn't want to participate because we didn't have a psychologist on the ground. But one of the things that was said to us is that it's okay if you don't have a psychologist on the ground. Can you see what pathways you could employ if you had to? Because even without participating in this study, there are patients who might need that kind of help. Where would you go? So that made us, as a service, sit down and map out a process as to what we would do. And we realized that we could employ the existing social worker in a care pathway. We could, if that was needed, but even before that point, we could actually send patients self-help resources to help themselves in the first instance if their anxiety distress wasn't that bad, then the social worker. And then it also forced us to think outside the box. We utilised the psychologist service at Westmead Hospital, which is the joint hospital in Western Sydney. We had psychologists there. We also looked out into the private sector. There were private psychologists who could help our patients. And if we worked with the patient's GP, we could organise, 8 free visits for that patient to access a psychologist's help. And so there you go, we'd mapped out this process, and all of a sudden, in this study, while we were working out this trial, when participating in this trial, we found our pathways. And that kind of stuck with us long after that trial finished. It made us use these other resources better. So in terms of what I've been doing in my own clinical practice, I'm a head and neck cancer doctor and a lower gastrointestinal tract doctor. Rectal cancer patients are the patients that I administer PROMS to, in addition to my head and neck cancer patients. So I administer PROMS relevant to those two groups in every single follow-up visit that they come, if they have been previously curatively treated. And my purpose is to identify issues in survivorship that I can intervene and improve. And in order to do that, I've worked with the speech pathologists and the dietitians, local psychologists who are already looking after my patients, to identify pathways where, if patients are scoring X on these questions, they have an automatic referral to these people, rather than all patients getting referred to see all of these health professionals. Does that make sense? So we're rationalizing the use of resources. Not everyone needs to see everybody, but those who need to see these allied health staff get to see those allied health staff. So in a way, we're utilizing existing resources better by adopting this process. Then the second thing I'm finding, and this is what I'm hoping to do next, this is what I mentioned to you when we spoke earlier, is to use population level data. So moving on from helping individual patients, which is crucial, that's the whole point of this. But by looking at what happens to whole populations of patients, we can actually see how we're doing as a service. We pick up areas of unmet need, areas where we have no resources that we need to get resources for. So by having this data, we're actually in a position where we could build a case to get an additional X, Y, and Z. Because without data, it's very difficult to advocate for these extra resources. So that's what's going to happen next, and hopefully will get us somewhere.
Well, power to your arm. I'm mindful of time, but Geoff, I want to come to you to hear you've started developing patient-reported outcome measures for people, patients from non-English speaking backgrounds. I think you've employed some special health workers that you describe as culturally congruent, speaking Arabic and Vietnamese to begin, and I think also for Indigenous patients. So just tell us what lessons you've learned and what more you're hoping to do in the next 12 months, please.
So touching on something that Puma just said, one of the things that PROMS does is it highlights unmet need and it quantifies it. So if we go to Puma's observation regarding psychological need, one of the benefits is actually if we highlight that 20% of our cancer population should see a psychologist, then that creates a quantification of the need for a service to be delivered locally. So I'd like to use the data at a population level to drive health service change. And there's quite a lot of data now in the Cancer Institute system that they have rolled out. So I'm in negotiations with the Cancer Institute about using some of those data visualizations to start to compare differences, let's say, between local health districts. Let's say, for example, we look at Puma's district, and if anxiety is higher or lower in her area, then that may also be useful data to look at health service changes. And we'd like to look at the groups that have lowest anxiety to find out, well, what features of that service make it like that, and then look at implementing something equally as good in other health services.
And if I could just quickly say for people, the Cancer Institute in the state of New South Wales in Australia takes a statewide view of what's happening in the cancer realm. So just tell us a couple of lessons you've got out of your work with non-English speaking patients and PROMS, and what your future plans are over the next 12 months.
So we haven't quantified it yet, but it's already identifying in my mind that whatever unmet need we are facing in English-speaking patients, you could multiply that by a number in non-English-speaking patients. Their levels of distress and so forth are very poorly detected by the system because of the clunkiness of talking through a third party, either another family member or a health services interpreter. And so we are identifying quite significant unmet need. Some of the unmet need existed before the cancer occurred, of course, because we're seeing patients from war-torn countries, for example, where their levels of distress and depression are off the chart already before they then are diagnosed with cancer. And some of these people are incredibly poorly isolated socially. And so it's really identifying for us this need to start developing culturally congruent care services that look after these patients in a holistic way.
I want to ask you one more question, and then I'll see if there's anything I've missed that you'd like to add. But, I think, Geoff, you're looking at working with computer scientists to have patient-reported outcome measures that score in some sort of visual way. And as I was listening earlier to both of you wanting, the report back that patients may do through their email or their phone. I've got one here, however you're asking them to communicate. You really need to develop close relationships with computer scientists and IT whizzes, don't you, to make this really work? But tell us what you mean by visualizations. What's your aim there?
So I'll give you an example. A patient comes into their medical oncologist and says, after 3 cycles of a particular chemotherapy, I'm terribly fatigued. And in the current world, the medical oncologist might say to the patient, well, that's normal. It is to be expected. It will get better. And that's often the end of the discussion. What I'd like to be able to do is to show that patient's patient-reported outcome measures against similarly treated patients who have also reported patient outcome measures. And if it is normal, I'd like to see the patient dot in the middle of all the other patients rather than off the scale. And that gives the patient a sense of normality. It's to be expected. But more importantly, I'd also then like to show the patient the normal trajectory of those PROMs over time. To say to a patient, well, look, for the vast majority of patients at this point, 90% of them get better, but you will have to be patient because it does take 4 months. And I think data visualization sort of enriches the understanding that the patient then has about why they're experiencing it, and more importantly, what to expect over the next few months.
Look, thank you. And a comment from you, Puma. What I'm hearing is that you two are applying the same commitment to evidence and data collection, analysis, to the experience or the views of the patient about their care as you do to everything else. It's music to my ears. There'll be some who think you'd already be doing this, but what's your final message to our audience?
On the point that Geoff just raised, I think that's a wonderful thing to be able to do, and visualizing the data, normalizing it for the patient, something that I'll be wanting to do for head and neck cancer patients. It's one thing telling them your dry mouth is going to get better when your saliva glands wake up at 12 months. But to be able to show them, look, this is where everyone is. Look at how, around 12 months, it starts to get better and it continues for another year, and you're going to be there. We just need to get there. That sort of visual feedback is wonderful. But yeah, coming back to your initial point, integration with the electronic medical record, I think, has been the biggest barrier to many of us. And I think it's because cancer electronic medical records have been locked systems, closed systems for obvious safety reasons. But, and we've had to work with the vendors very closely in order to create communication channels in and out of those locked systems. But integrating it is going to be the key. So working with vendors who provide the cancer EMR, so they're the same people who actually vendors for the machines, the Linux. So, it has to be a team effort. It has to be a two-way process and can't be a commercial exercise where, they're hoping to sell new software that allows the collection of PROMs. It has to be to benefit patients and has to involve clinicians. So I think that's a key thing. And my message to clinicians out there listening to this is start somewhere, start anywhere with whatever you've got. Because when you look at it, it is so big with so many barriers at the patient level, at the clinician level, at the health service level, that it all feels too hard. But start somewhere from wherever you're at, and you can build on it and improve on it.
Well, look, thank you so much to Professor Geoff Delaney and Associate Professor Puma Sundaresan. And please share this video with patients and families and multidisciplinary clinicians who may be interested, who are also advocating to improve survival quality of life for cancer patients. Thank you very much.
Thanks,
Julie.